I'd like to welcome everyone to the Buncke Clinic Virtual Visiting Professor Series. Today, I have the pleasure of introducing a dear friend, Dr. Dan Zlotolow from Philadelphia. Dan is a surgeon at the Shriners Hospital for Children in Philadelphia, and he is also Associate Professor of Orthopedic Surgery at Thomas Jefferson University and Temple University School of Medicine. A few slides by way of background. Dr. Zlotolow did his undergraduate at Haverford College, followed by MD at the University of Pittsburgh. Then he did his orthopedic surgery residency at Montefiore Medical Center in New York City. He then stayed in New York City and did his hand fellowship at the Roosevelt Hospital. And then he did a nerve and pediatric hand surgery fellowship at Texas Scottish Rite Hospital and the Shriners Hospital for Children in Philadelphia. Dan has published more than 60 peer-reviewed articles. He has written 2 textbooks and 50 book chapters, so quite prolific. He has organized more than 20 meetings and courses nationally and internationally. He has mentored more than 100 hand surgery fellows. He serves as an associate editor for the Journal of Hand Surgery, and he founded the Manus Group. If you guys recall, a couple of weeks ago, we had Dr. Jeff Yao, who is also a member of Manus, and we have a couple more coming up in the next few weeks. He has also founded the Plexus Nexus, as well as the Pediatric Hand International Society of Surgeons. And his practice focuses basically on very complex pediatric hand and peripheral nerve surgery, everything including cervical spinal cord injuries, peripheral nerve injuries, the management of amputations and replantation, upper limb sequelae of stroke and traumatic brain injury, arthrogryposis, congenital differences, and his topic for tonight, which is pediatric brachial plexus. Dan, thank you so much for being with us. It's really an honor to have you, and we're really looking forward to hearing your talk.
Thanks, Buncke. The honor is all mine. I think if you look at the list of who has spoken at this lecture series, it's impressive and a testament to you guys that you were able to attract this level of speakers. So congratulations and kudos.
Thank you.
So I'm going to talk about things that I've learned, things that we have learned. I think one of the really take-home points for me in terms of practice is how much more I have learned and how much more we have progressed having a mentor-mentee colleague relationship with Scott Cozen. And if you look at across the history of surgery, there's often a Laurel and Hardy, a 2-surgeon combo. And I think the reason for that is because we've been able to push each other. And everything that I'm going to present here is things that we have sort of bounced off of each other and we have learned together. And I don't think it's things that we could have learned on our own. So let me just minimize. All right, so this is hot off the press. I just finished it about a half an hour ago, so hopefully it'll go well. All right, let's see. So first off, again, standing on the shoulders of giants, right? Everyone from Naracus, Malacy, Gilbert. I mean, these are the greats that I have learned from and that really influence how I think about the practice of brachial plexus surgery. And these are the young guns, and I put myself there in the company of some really great people, people that I rely on and have taught me many of the things that I'm going to be presenting here as well. So I think the plexus world is very much alive, and I've certainly left a lot of people out, but these are the people that I go to when I have questions, clinical questions or basic science questions. We put together Plexus Nexus, which Bobek mentioned. I think it's a really, it's in its infancy right now, but it will become a very useful patient and clinician guide in the future. And really, I think we're just beginning to understand pediatric plexus, baby plexus. We don't really understand the injury, the anatomy, the nerve physiology, the diagnostic studies, what we should use, surgical options for nerve reconstruction. are all over the place. And options for shoulder dysplasia, I think, are just beginning to come into view, even what it is that we're doing, and even whether there's any need or how to optimize rehabilitation early on. So let's just start with classification. So I think just to have everybody on the same page, we're going to be talking about upper trunk injuries, and that's your 5-6 injuries. Most common, these are the most common injuries, about 50%. You have your shoulder dysfunction, which includes basically all the 5-6 innervated muscles, your deltoid, upper subscap, supraspinatus, infraspinatus, elbow function, so all your elbow flexors, and some wrist extension. Looking at extended upper injuries, these are 5, 6, and then 7, about a third of all injuries. And these add lower subscap, latissimus, et cetera, down to loss for sure of wrist extension and pronation, weakness, FCR. And finally, global injuries, which are involve the entire plexus. That can be with a Horner's or without a Horner's. Horner's is a worse prognosis. That's when you have a little eye droop. And it's generally a marker for an avulsion, and we'll talk a little bit more about that. And then you have your lower plexus injuries, which we really never see in a pediatric baby situation. So baby injury, we've never seen it. Scott's never seen it. I've never seen it. I think no discussion of a nerve injury can really begin without discussing this classification, where you have your neuropraxia, axonotmesis, neurotmesis, and then the various different kinds of neurotmesis depending on how disconnected the nerve is. Now keep in mind that where the brachial plexus injuries is a traction injury, it is not a laceration in babies. And so this doesn't exactly apply, and I'll get into that to some degree. So when we look at the degree of injury, we're looking at neuropraxia, which is a myelin injury. Myelin is the most sensitive of the tissues in the nerve, and so it's the first to be injured, and therefore this is your lowest energy mechanism. And they recover spontaneously within about 2 months. Axonotmetric injuries, axons are torn, but the nerve structure is in continuity. So the endoneurial tubes are in line, and all the nerve has to do is just grow out. And it has a nice roadmap on how to get back to its target organ. And we know from crush injuries that, which are axonotmetric injuries primarily, that these do very well, both in animal models and in human clinical experience. Recovery is time dependent, and we have this 1 inch a month or 1 millimeter a day, which is probably grossly inaccurate, but that's what we stick to. And I'll get into that as well. Neurotmesis, you have the nerve that is torn or cut, and therefore there's no recovery without surgical intervention, or at least very minimal recovery. This is a diagram that I did as our patient handout. And so I talked to patients about, well, you have a baby with 20,000 fibers per root, and they can undergo a neuropraxia, axonotmetric injury, neurometric injury. And then below is avulsion, and we'll get to that as well. So lots of previews of coming attractions, but it's a pretty dense talk. The clinical implications of these injuries is fairly straightforward, at least the way it's been thought of previously. So your neuropraxia usually resolves by 2 months. So if you follow the kids out, by the time they usually get to a brachial plexus specialist, they're older than 2 months of age. So generally speaking, you see them, they're better, you send them home. Axonotmetric injuries, these typically improve spontaneously by 5 months, or this is the party line. And for the upper trunk, and it can take up to 2 years for lower trunk axonotmetric injuries because of this 1 inch a month. The more proximal C5-6 innervated muscles will recover first, then your C7 muscles, which are more distal, and then the lowest are your 8 and 1. Neurometric injuries, you see minimal or more delayed spontaneous recovery, again, because you've now disrupted the endoneurial tubes, and the axons don't necessarily know where to go. And results are better with surgical intervention. All of the surgical indications that we have are based on this paper. This is the foundation, and this is what your OITEs and when people think about the plexus, they think about this paper. Single author, Peter Waters, one of the greats, and made tremendous contributions to our understanding of brachial plexus birth injuries. And he based this study on the MAL-A, which is all that he had available at the time. MAL-A is a test, it's an outcome measure looking at shoulder function only. So he based his study and based the recommendations of surgery on elbow flexion with an outcome measure of just how they behaved in the shoulder. Didn't look at recovery in the hand, didn't look at recovery even for elbow flexion as a criteria. So clearly, I think this is a good first step, but we had a lot more to go. Then you have Howard Clark, who came up with this algorithm, and you have a child with a plexus injury and global injuries. He would operate at 3 months. Then around 6 months, which is essentially the Peter Waters recommendation, if they didn't have elbow flexion, at that point, they underwent nerve surgery. And he came up with this idea that if they're making progress at 6 months, maybe we should wait. And if they're improving, then we wait till about 9 months. If we wait till 9 months and they can't take a cookie, and I guess a 9-month-old can get a cookie, really wants a cookie at that point. You can take that cookie and put it to your mouth. And that means that you've recovered enough function that you'll do fine and you don't need nerve surgery or plexus reconstruction. Seems very logical, and actually there's a lot of thought behind that. The problem is it really didn't hold up. So the cookie test crumbles. I thought of other things like the cookie test has gone stale. Anyways, take whichever you like. So the problem is that the cookie test, getting a cookie to your mouth, requires 2 things. It requires elbow flexion, yes. But if you're stuck in internal rotation and you try to bend your elbow, you can't get that hand to your mouth. And so there were a lot of children that failed the cookie test, not because their nerves weren't recovered sufficiently, but because their glenohumeral dysplasia, which is a deformity of the shoulder that baby plexuses get, limited external rotation. And therefore, even if they had near full recovery of their nerves, people went in, and still today, because people still do the cookie test, fail that test, and they cut out a working neuroma in continuity that is transmitting sufficient function for elbow flexion and even some shoulder. So I think this is something that we have now learned, and Howard Clark agrees with this view that the cookie test may be a little overblown. So what is this glenohumeral dysplasia? Well, again, looking at where we've come from, posterior shoulder dislocation in infants with neonatal brachial plexus palsy. This is a landmark paper with Peter Carter as the senior author, Mary Beth Izaki, and Dieter Mukoko. And what that showed is that glenohumeral dysplasia happens very, very early, and it can be picked up on ultrasound. So here's an ultrasound. Glenohumeral dysplasia can be evident as early as 3 months of age. The one on the left is the dysplastic shoulder. The one on the right is a normal shoulder. And you can see that there's already posterior translation as early as 3 months of that humeral head on the glenoid. So what is happening here? Why is this deformity occurring? And how do we characterize it? Well, going back again to Peter Waters, you have this radiographic classification of glenohumeral deformity, normal, pseudoglenoid, and infantile dislocation being the worst. So theories of how this occurred: glenohumeral dysplasia imbalance theory, right? So if you actually look at, this is a drawing I did many years ago. Thankfully, my drawings have improved since then. If you look at the internal rotators, latissimus, your teres major, your subscapularis, and your pectoralis major. Whereas you have very weak external rotators, your teres minor, obviously your minor is weaker than your major, and your infraspinatus. So if you denervate these external rotators, you have a huge whopping mismatch in your imbalance of the shoulder. And that forces the head towards the back of the joint. And that's what was thought was leading to this dysplasia, is this imbalance. And there was some evidence for this. We published a paper with Francisco Soldado many years ago, actually 6 years ago, not many, where we denervated the suprascapular nerve. So we removed the suprascapular nerve, and that was sufficient to actually cause all the kinds of problems that we were seeing. So it was fairly supportive of this. Well, if you denervate the external rotators, you're going to get this kind of glenohumeral dysplasia. But this paper, I think, in 2011 by the Cincinnati group with Roger Cornwall as the senior author, that this took a while to catch on, but I think now is accepted doctrine. And that is that impaired growth of denervated muscle contributes to contractures following neonatal brachial plexus injuries. Now, how does this happen? Well, they've done many studies since then, and it turns out that if you cut the axon of a neonatal rat, what ends up happening is the spindle fibers, which are sensory organelles within the muscle that sense stretch in the muscle, those organelles are not formed at birth. They form post utero. So if you cut the axon, that spindle fiber never develops into a fully formed spindle fiber, and therefore the muscle will not sense growth normally. And therefore, when the skeleton begins to grow and enlarge, it lags behind in sensing that growth and therefore itself growing. And so the muscles remain short relative to an elongating skeleton. And this was a huge landmark in our improvement in our understanding of what was going on with the plexus, what was going on with the shoulder. And interestingly also why we were getting elbow flexion contractures. That was a mystery. But almost all the kids with plexus injuries, baby plexus injuries, get elbow flexion contractions. And it was the same mechanism. So what do we know today? Right? Yesterday, imbalance leads to glenohumeral dysplasia. Today, we know that, yes, that's true. Imbalance of the forces does contribute. But it's also this denervated muscle that doesn't keep up with skeletal growth, and the rotator cuff gets tight. And because the shoulder is so dependent on the rotator cuff for stability, it leads to dysplasia posteriorly. So I'm going to show you how this basically happens in a schematic, and it's all due to the Futter-Volkmann law. Compression forces inhibit, inhibit growth, and tension forces stimulate growth. So here's a baby with a neonate with a plexus injury. One second. And if you begin with this imbalance theory, and now the shoulder is internally rotated, well, we know that when you internally rotate your shoulder, the glenohumeral joint or the head moves posteriorly on the glenoid. And now you're loading the posterior glenoid. You're going to restrict the growth of the posterior glenoid, particularly because the muscles are so tight and they're holding the head against the glenoid. And over time, the anterior glenoid grows, the posterior glenoid is stunted, and you get this shape. Now, what's even more interesting, and this is a very recent discovery of ours, we have not yet published this, and I don't think we have the numbers yet to publish it, but glenohumeral deformity actually changes the line of pull of the rotator cuff. So to give you an example, I had a patient that had no external rotation, but had recovered almost everything in the arm. And it was just an upper trunk injury, but all the child could do is abduct, and when they abducted, they internally rotated. And there was no active external rotation, despite having good passive external rotation. Well, being the good nerve surgeon that I am, I booked them for a spinal accessory to suprascapular nerve transfer, and I got them to surgery, and I looked at the suprascapular nerve, and as I always do, I stimulated the nerve. And what was amazing to me is that when I stimulated the branch to the infraspinatus, I got pure abduction at 0.5 on a checkpoint that was 0.5 milliamps full mid pulse width, which is a normal nerve. And then I stimulated the the supraspinatus branch, and all I got was abduction and internal rotation, primarily internal rotation. So what had happened is, as the shoulder internally rotated and the glenoid moved, the head moved posterior relative to the axis of the scapula, the supraspinatus became an internal rotator, and the infraspinatus became an abductor and not an external rotator, which is fascinating to me. And I think it's one of these things that we need to further investigate. And it really sort of explains why, when you see this disconnect between what's going on in the shoulder, which is 5-6, and what's going on with the elbow, which is also 5-6, and why one works and one doesn't. So prevention of glenohumeral dysplasia has been the key for us. How do we do that? Passive range of motion with diaper changes at home or with the therapist several times a week. External rotation with the shoulder adducted will give you subscapularis stretch. If you are externally rotated with your shoulder abducted, that's going to give you a pec major stretch. And then also the latissimus and the teres major will be stretched as well. And then avulsions, which is interesting, and this has to do with Roger Cornwall's study. They don't get as tight. Why? Because the spindle fibers in an avulsion, because their sensory organelles are part of the dorsal root ganglia, which are preserved and not injured when there's an avulsion event. And I can get into that a little bit later. So how do we prevent these deformities in the shoulder? Well, if you're a Canadian, you get a super splint, which is a great name, at least from a marketing standpoint. The idea is it supinates and externally rotates. And one of the other problems that children have, as I just mentioned, excuse me, is that the elbow gets a flexion contracture. Well, what could possibly be wrong with that? We've had several cases of supination in a splint that led to posterolateral rotatory instability of the elbow. That means as you hold them in supination, you're actually stretching their ligaments. And this is a baby, relatively speaking. These are young neonates. And you can stretch those ligaments enough that you can cause rotational instability of the elbow, particularly the radial head. The other problem is that you can't control supination or external rotation with the elbow in extension. And this just makes sense. It's like trying to keep a tube from rotating inside another tube. It's nearly impossible. So we've gone to this, which is our teapot splint, and there are many, many variations, and many people have a variety of different adaptations of this. We try to steal ours from the University of Cincinnati, and we've made our own modifications to this. And this has problems too, in that you can see the elbow is held in flexion, and that's one of the problems. But at least this allows us to control the shoulder better, and we've had great success so far with the teapot splint in minimizing glenohumeral dysplasia and stretching those hard to stretch internal rotators. So what happens to the shoulder over time? As I mentioned, denervation of the deltoid, the upper cuff leads to tightness of the deltoid, the teres minor, etc. And what happens is, as these muscles get tight, the capsule, which is underneath, has no incentive to grow because it's never moving. Therefore, you get these global glenohumeral joint contractures, which are capsular contractures, abduction, adduction contractions, cross-body abduction, adduction contractures, and rotational contractions. And these are very limiting for these patients. And what's the result? The result is scapular winging. There is no patient that has suffered a brachial plexus injury and not spontaneously recovered at 2 months, by 2 to 3 months, that does not complain of scapular winging. And it's almost every office visit I see a patient, this is what the family's concerned about. And what is it? It's compensatory scapular winging that happens in nearly all patients again. And it is a cosmetic problem, but it is a functional compensation. What are we talking about? We did a study years ago looking at scapulothoracic and glenohumeral motion using motion analysis lab. It turns out glenohumeral motion decreased in all directions compared to controls for children with brachial plexus birth injuries, even in ones who had no surgical intervention. Increased scapular motion was then used to compensate to achieve the same functional goals. However, this motion was the worst, the scapular winging was the worst in hand-to-mouth position. which is essentially cross-body adduction. So if your preventative measures don't work, then there's always been the go-to, which is this modified Hoffer procedure. And there are about 1,000 different modifications of the Hoffer procedure, and many people use it as a marketing tool. They create their own name and try to market it as a completely new idea. But it's basically, they're all essentially the same. So you have tendon transfers without release. You have selective latissimus or teres, or sometimes both transfers. And then there's this concept of coracoid osteotomy, which I'll get to as well. Your setup is a lateral decubitus position. We inject, posterior approach, posterior axillary approach. That's what it looks like. If you've never seen it, it's like operating upside down and backwards while hanging from the ceiling. But once you do it a few times, it's actually very straightforward. And there's your lat and teres, the lat being the more tendinous portion, the teres being the more muscular portion. And you can release one or both tendons, and we've done both. And you can reroute it over the triceps into the infrasupraspinatus footprint. And as I showed you earlier, when you have this dysplasia, the more posteriorly directed tendons, like the infraspinatus, is shifted to be more anterior and therefore is an abductor. The idea is this, and one of the ideas why this may actually work, is that it is a now more posterior structure which is pulling you into external rotation, which you couldn't do before with the native muscles, even if they're innervated. And here's the idea. You're just basically putting it into a position for external rotation and abduction. The results can be quite striking. There's a child pre-op on the left, and you can see cannot reach his ear, and there's the child post-op with much better abduction. And by the way, that's his maximum abduction on the left. And look at that improvement. This is a child who recovered active external rotation and active abduction, which is not the case in all kids. We did a study years ago, again, looking at whether to use one tendon or both tendons. And we've subsequently done another study looking at that. It turns out it's basically dealer's choice. So here's your latissimus and teres major. I do a teres major only. Scott does teres and latissimus. Turns out they're both about the same. One may have a slightly decreased risk of some things, and one may be slightly better, but statistically, they're essentially the same. So here's our matched cohort. Again, some differences, but basically the same. So another issue that has come up is whether or not to do arthroscopic versus open release of internal rotation contractures, and whether to do that at the same time as your tendon transfer. So this study showed some improvements with arthroscopic versus pectoralis major tendon Z-plasty group, right? So not exactly the same kind of open release that we're doing today. And then the lower trapezius transfer emerged, and this is from another Manus member, which is this lower trapezius transfer, which Bassem El Hassan at Mayo had really championed. He didn't invent it, but he certainly put it back on the map after it had gone away for many years. And maybe just best for external rotation and not so much abduction, may serve as a humeral head depressor to augment abduction. And again, still investigational. Perhaps using it as a bipolar may help. I think this is, jury's still out on how to use this. But that's basically the idea of the lower trapezius transfer. We used to use this 2-incision technique. We now use a single incision technique, again, based on Bassem's recommendation. And you isolate the lower trapezius. We don't use a graft anymore. We sew it directly into the infraspinatus tendon, which may actually be a mistake depending on the level of dysplasia. And then we attach it to the infraspinatus. This is our best result ever. Most of the results are fairly lackluster, but this kid really does have active external rotation. You can see he's cheating a lot, but his injured side is the left. And then another procedure that we were talked into was this upper trapezius and levator transfer. And this became a disaster in babies. If you take away the acromion, which this operation makes you do, the humeral head with all these tight muscles will rise up and out of the shoulder like a periscope. So that is I would say, do not do this unless you really want to tempt fate. So again, what have we learned? Yesterday, tendon transfers improve abduction and external rotation by improving active motion and preventing dysplasia. Turns out that's not really true. That happens in some cases, but in most cases, actually all it does is it changes but doesn't augment the glenohumeral motion arc, which means it doesn't do that much better than a humeral osteotomy. The other thing that we've learned is that all of these procedures, regardless of what you're doing, if they increase external rotation and abduction, you're going to lose internal rotation. So here's a child who, this is after his tendon transfer, and you can see his abduction is really good. His external rotation is great. We're thrilled. We're so happy. Mom's high-fiving us, right? And then she says, you know, but he can't pull up his pants, and he has difficulty with his buttons. And here he is. Look at the smiley happiness. Look at the sadness, right? And as I said to Scott, I'd rather be able to button my buttons and pull up my pants than high-five my neighbor. So this internal rotation is much more important than external rotation. And if you look at the Mallet, and this is a Mallet classification that I referenced earlier with Peter Waters' study, the Mallet, traditional Mallet scale ended at hand-to-mouth function. Scott Cozen added the internal rotation, which is the bottom. Let's see. Right. And so our child would have not been diagnosed as losing midline because we weren't looking for it prior to this classification or this addition of the Mallet outcome measure. And he had a grade 2, which is he cannot even touch with with wrist flexion, which is a grade 3. A grade 4 is you can touch your belly with your wrist flat. And so when we looked at our patients that we had done tendon transfers on, we had 172 patients, and 20% of them lost midline function. 20% of them were not able to reach their bellies, even with wrist flexion. That's a very high number. And if you look at the number of procedures, most patients only had 1 or 2 procedures. And what did we find out in terms of why? Right? So if you look at the 5-6 injuries, 5-6 injuries had very few. It was essentially very few loss of midline events. But the 5-6-7 injuries were very high, and the 5-6-7, 8, and 1 injuries were even higher still. If they had a plexus exploration, the odds ratio was 2.5. If they had a sural nerve grafting, 2.8, essentially the same. If they had a surgical glenohumeral reduction, either arthroscopic or open, which I mentioned earlier, regardless, they still had a much higher risk of losing midline function. So if their joint was tight and you released it and put the head back towards the front, they still lost motion. And here's a graphic representation of this. And I think this is the take-home point from a loss of midline standpoint. 11% for 5-6 injuries, but almost 40% of children with global injuries who had a tendon transfer for external rotation and abduction lost the ability to button their buttons, get their hand to their face well, and pull up their pants. And these are very limiting things. So our indications for tendon transfer as a result of these studies has therefore changed. Sure, we use it for loss of superior posterior rotator cuff function, but we now feel that they have to have deltoid function in order to get overhead motion, but also they have to have normal C7 function. Again, when you have C7 function affected, your loss of midline is much higher. Part of that is because the subscapularis is segmentally innervated, and when you lose the upper subscap, you still have the C7 innervated subscap to give you more internal rotation. But once you lose 5-6-7, that subscap is no longer working normally. and it is very hard to get back to midline. Again, these are Mallet internal rotation scores of 4 or 5 in order to be able to even qualify for an external rotation tendon transfer. So the other option, which has been talked about for a long time in practice for a long time, is humeral osteotomy. Generally speaking, this has been reserved for patients whose glenohumeral dysplasia was so severe that it was not even worth going after, and late presentation, so after 4 years of age, and again, severe glenohumeral dysplasia. And it improves external rotation, which is comparable to a latent teres transfer, but doesn't improve abduction, as you would expect. Here's let me see if here's the basic procedure. I'm not going to get into in detail. We use a medial approach and gives you a nice surface to put it in, and it's very cosmetic. It is much more difficult from a technical standpoint, however, because you're looking at all the nerves in the arm. So what are the results of these osteotomies? Well, quite good. Again, Peter Waters, Don Bay, 2006 article. They had really good results with an improvement of 65 degrees, essentially, on average for external rotation in patients who had had severe glenohumeral dysplasia. And then more recently is this concept of the glenoid osteotomy. And I would credit Kevin Little for being the one who at Cincinnati who introduced this concept to us. And the idea of a posterior opening wedge didn't make any sense to me, because if you have structures that are really tight, why do you want to open the wedge? But somehow this actually works. And this works particularly in the kids who have an in-out glenohumeral joint. So these are kids who have a biconcave, perhaps, joint where the head sits front and sits back, and they put it in the front to be able to do external rotation and abduction, and they kick it in the back to be able to do internal rotation. But after a while, that becomes painful in many kids, and they want that stability, in which case we can do this glenoid osteotomy. Here's a picture from, this is a still from one of the videos on our Little Arms website, which I encourage you to visit if you want more information. And here's a piece of iliac crest put into the posterior glenoid to elevate the glenoid. That's what it looks like from the side. And you can see that we've gotten a pretty level joint in a child with pretty severe glenohumeral dysplasia. I'm going to skip the video. So that's a marathon on what's going on in the shoulder. Let me just talk about the injury as well, because I think there's a lot of basic science that's missing that helps us really inform how we treat these patients. So I mentioned earlier this degree of injury, this neurotmesis, axonotmesis, but in reality, it's different because these terms are oversimplifications. It's not a winner takes all kind of situation. You don't have all axonmetric injuries or all neurotmetric injuries. You can have a partial neurotmesis. You can have a partial axonotmesis. You can have partial demyelination. And so it's really much better to think of it as a percentage of what's intact and what's not intact. Percentage of intact versus not intact axons. And the term that's commonly used now is axotomy. So the percentage of axotomy. And what does that mean? When an axon is disrupted, that axon is referred to as being axotomized. So that's an axotomy event. Your demyelination is your loss of myelin, and you have a percentage of that. Not all of your axons are going to be demyelinated evenly. Some of them will be demyelinated a little, some of them a lot, some of them not at all. And that degree and that injury depends on the degree at which you stretch. And then there's a percentage of intact macro and microstructure. There may be some endoneurial tubes that still line up, but some may not, especially as you are introducing a pull, like a taffy kind of injury, rather than a laceration kind of injury. So it looks more like this. This is from a graph we did for the recent Mayo book that hopefully will be coming out soon on brachial plexus injuries. And you can see that as your strain increases, the percentage of axons is injured. These are not exact numbers, so it doesn't have a scale, but the concept is there, that you have initially a demyelination. And then as demyelination is occurring for some axons are undergoing axotomy until you reach a point where the entire nerve is ruptured, and then you reach a true neurotmesis event. So remyelination of the intact axons, the myelin is very sensitive to stretch. And when the injury happens, it results in these Schwann cells losing that myelin and reshaping in order to become phagocytic cells. And they will resorb the myelin themselves along with the macrophages. Your Schwann cells will remyelinate bare axons after all that debris has been taken away. And that process is complete by about 2 months. So we know that from animal studies, and we know that from clinical experience. Axotomy is a little different, of course. And 3 to 4 weeks after injury, you have termination of this Wallerian degeneration, and your proximal Schwann cells will start crossing the injury site. That happens really at around day 10. Some cross initially, but by day 10, you're really getting some movement of Schwann cells across the injury site. There's no directional bias. Some axons go backwards, some axons go forwards. It's like the Wizard of Oz. They went that way, right? And then there's no functional bias. There's no preference for motor Schwann cells versus sensory Schwann cells between sensory and motor axons. They just go wherever they can initially. And they're very slow to move out. So you have this initially very slow outgrowth followed by a deluge of growth. And this is one of the reasons why people have looked into nerve stimulation as a way to get all the horses to the gate and the gate to open all at once, as Amy Moore has said. So it's just if you can stimulate the nerve directly, that actually gets all of those axons geared up to feel like it's a fresh event, and they go out all at once. And so you have earlier recovery in theory, and there's some evidence to back that up. And so what happens as these growing axons get to their target muscle, you see minimal function at first, because only a few muscle fibers really connect. And then the motor unit expands, and strength begins to recover. And the timing is proportional to the distance traveled, right? How long it takes for the axons to reach their target muscle. It's clearly faster than 1 millimeter a day or 1 inch a month, even in older people. And in babies, it's probably more like 2 to 3, maybe 4 or 5 millimeters a day. But a lot of things need to happen once that axon reaches the muscle. And again, the timing is affected by age and comorbidities as well. And so what happens is there's an expansion of the motor unit. So you're an axon, you reach the motor unit, and now you have to expand. So what is a motor unit? Motor unit, everyone in this call probably knows what this is, but just for those who don't, for the fellows and residents out there, motor unit, one axon, and up to several hundred muscle fibers that are distributed widely throughout the cross-section of the muscle. So it's not that a motor unit is one axon innervates one section of the muscle. It's actually innervates muscle fibers throughout the entirety of the muscle, which makes sense from a teleological standpoint, because that's what you would want. So if you lose some, you're still going to have a wide distribution of intact residual motor units that are still working. So a normal innervated muscle, only 4 to 6 muscle fibers of a particular motor unit are innervated within the pickup range of an EMG needle. So when you put that EMG needle in, you're really only getting 4 to 6 muscle fibers, which represent one motor unit. And that's what you see as this 2 millivolt with a 5 to 10 millisecond duration amplitude, right? If you partially denervate that muscle, after terminal sprouting is completed, you see amplitudes of 20 millivolts, so a 10-fold increase in the size of these motor units in some cases. And so this is telling you that something has happened where that axon, instead of controlling several hundred, it may be controlling several thousand muscle fibers after an injury. And that's what you see on the EMG that they call reinnervation or evidence of reinnervation. So this is again from that Mayo book. This is a figure we did. This is your myelinated axons in a pre-injury situation. And now you've lost this exotomized axon. So one of the 3 axons to this area was lost. And what you have is the perisynaptic Schwann cells searching for viable axons anywhere nearby. And you have that denervated muscle fiber. And then the remaining myelinated axons will nodally and terminally sprout to help cover that, that muscle fiber. And again, that's multiplication factor can be as high as 10-fold. We believe that to be around 5-fold in general. So the timing and the likelihood of recovery is tied in to this injury severity as we understand it on a more micro level, more granular level now than I think we did many years ago. And that remyelination, again, typically takes about 2 months. But while remyelination is occurring, there's a lot of other things happen. That exotomized axon is growing out from the injury site. And again, this is age dependent, both the speed and the rate of the axons, meaning the number of axons that make it across. It's microstructure dependent. How many endoneurial tubes line up and how close are they? And how much of a neurometric kind of injury is it? And they remyelinate as they grow out. Intact axons are undergoing terminal and nodal sprouting. So when they reach their target organ, or the ones that are remaining, they're actually amplifying. So a lot of things are happening. Remyelination is happening. Axonal outgrowth is happening. Remyelination of the axonal outgrowth is happening. And the intact axons at the target organ are also undergoing terminal and nodal sprouting, where they can cover an injury of 80% exotomy and completely recover with no clinical sequelae by 4 to 5 months. However, going back to the Roger Cornwall paper, they do not recover that sensory component of the spindle fibers. And therefore, even though the muscle may have normal contractile properties, it will not grow. And so bringing it back around, that really changes the way that we think about what's going on in baby plexus. Again, this is your disruption of endoneurial tubes, and it's not an all or nothing phenomenon. I think that's what I want to get across. So I'm now, with 10 minutes left, I'm going to, well, let me talk about this as well. Beyond that, you have this issue of recovery of cortical control. So Martin Malacy in the Netherlands talks a lot about this. After all of this has occurred, your brain has to figure out where did these axons go and what are they doing. And that takes time. How much time, we don't really know. But there is a problem where you have this cortical misorientation, where you'll have axons that used to go to the biceps, go to the triceps, or go to the shoulder, or go wherever. And I do some mission work. I was in Rwanda on a brachial plexus mission trip, and I saw a lot of patients who had good tone in the biceps, good tone in the triceps, but all they could do was fire both at once. So this co-contraction of biceps and triceps is very common, and a Botox can actually reboot the system. And since I am now 10 minutes to go, I'll stop for questions. Let me do one more thing. This is really interesting, and this is hot off the press here.
Dan,
So,
there's plenty of time, so take your time. This is great. So cover
okay.
as much as you want. There's no rush.
All right. How much time do I have? Doesn't.
As much as you want.
All right. All right. So, in which case, get comfortable, everybody. We're here for the rest of the evening. No, so let me just talk about C7 injuries, because I think this is something that is very poorly understood. Certainly, we don't understand how this occurs, but we've seen so many examples of this that it's hard to ignore. And I'll give you an example. Here's a C7 injury. There's your dorsal root ganglion right here, and here are your ventral rootlets. The only way I have access to that if that was avulsed. If it was a rupture, that would have been sitting inside the spinal cord and I'd have no way to get to it. In this case, the C7 root was found intraoperatively anterior to the anterior scalene muscles, so right next to the phrenic nerve, nowhere near where it should have been, and with no possibility of contact between it and the spinal cord. So there was no proximity to any other root as well, because it was sitting completely in the wrong place. And again, you can see these dorsal root ganglia and ganglion and the ventral rootlets. And this is what it looked like once we peeled it off the anterior scalene. It's clearly avulsed. I'm going to show you a video because this patient had elbow extension preoperatively, but it was always on, sort of like you would see with cerebral palsy. This child had just straight arm all the time. Let me see, it's not playing. Oh, here we go. So there's the injury. And here we are stimulating the avulsed nerve root. And it is giving us triceps function. Not only that, look at the fingers. It is clearly giving us C7 function. Finger extension, a little bit of wrist, and clearly triceps. So what is going on here, right? What's interesting is we think that the C7 avulsions, and it doesn't happen very often with lower trunk avulsions, it's a particularly C7 event, that when you pull in the right direction, you actually can avulse some of the anterior horn cells, which will persist in the ventral rootlets. And therefore, you have a upper motor neuron injury alongside your brachial plexus injury. And so oftentimes, you base your surgery on your clinical exam, they will have triceps, they will have finger extension, but they'll always be on. They'll look more spastic than normal. And beware that this may represent a C7 avulsion that is conducting. So in these situations, we always look for C7 just to make sure that it is not avulsed, even if clinically it doesn't look that way. And I've seen many examples of other surgeons, and certainly we're guilty of it up until recently, of assuming that this was working and leaving C7 alone. But this clearly needed to be reconstructed. One other thing, Bobak, if that's okay. We'll talk about the brief anatomy because I think this is also really important. If you look at the way that the books say the anatomy is shaped, they do not talk about sagittal plane alignment. They don't talk about the way that C7 is posterior to 5 and 6 and follows really the curve of the spine. So as you have this lordosis, you expect these roots to be falling further back. But it's even more than that would account for. The other thing that I think is really confusing is the anatomy of the cords. The way that they're drawn is a posterior, a medial, and a lateral, right? And that is completely wrong. The reality is the lateral is anterior, the medial is posteromedial, and the posterior is posterolateral. This has real world implications because oftentimes when you're looking at the divisions distally, looking for your reconstruction, I've seen people put what should be the posterior division of the upper trunk and they think it's the anterior division because of the location of these cords. This is a real problem. And I think if you understand that the cord is, the plexus diagrams are misdrawn and that the most lateral structure is the posterior cord, which if you think about it, makes perfect sense because where's that posterior cord going? To the most lateral structures. It's going to the axillary nerve and the radial nerve, which are the most radial structures or the most lateral structures, neurologically speaking, in the arm. The other thing that you will see is these drawings, which shows this bifurcation of the upper trunk, but not so. We published a paper years ago, again, that it is a trifurcation, and this is what it looks like. The posterior division is in the center. The anterior division is more medial, and the most lateral is the suprascapular nerve. And if you know, again, if you think that the posterior cord is not lateral, and you think that it's directly posterior, and that the lateral cord is actually lateral, you're going to mistake that anterior division for the posterior division and vice versa. And your reconstruction will be way off. And the marker here is your suprascapular nerve. And I'll leave it at that. I had a bunch more, but I think that's plenty of plexus for one night.
Well, Dan, this was great. You know, as someone who doesn't really do any plexus and definitely doesn't do any PD plexus, I think
Right.
this is exactly the kind of talk that I think we need as part of our library, because I think I can just see surgeons and residents and fellows accessing this video for years to come. So thank you so much for that. And you know, I love talks where I learn a lot myself, because as I mentioned, I don't really do this stuff, and so the whole time I was learning a lot of things, and I found a lot of the work that you're showing with the sprouting of the axons toward the denervated muscle fibers. That was really fascinating, and also the fact that the growth rate of a lot of these axons is a lot faster than we traditionally think, which is the roughly 1 millimeter a day or so. So that's something new as well.
Yeah, it's fascinating. What's I learned that, I think, from visiting Dr. Xu, Wengdong Xu in China. He was doing these contralateral C7 transfers, and within 3 months, the patients were getting paresthesias in their pec.
Wow.
No way that's possible with a 1 millimeter a day, and these were adults. And I saw that with my own eyes. I mean, that convinced me that we were completely wrong, because there's so many other steps that need to happen, and I think we just haven't understood from a micro level what was happening at the nerve level.
Yeah. Now, speaking of the contralateral C7, what are your thoughts on that? I know it's kind of fallen out of favor here in the West, but what are your thoughts?
So we do contralateral C7s. I think the only other people who do it on a regular basis would be Cincinnati in terms of baby plexus. Our results have been mixed. We've had some phenomenal results, and we've had some not so great results. I can't tell you exactly why. We just don't have the numbers. We're certainly less than 10. We're more than 5. I don't know where we are. But I think one of the reasons that contralateral C7 fell out of favor was because of the Mayo experience with the using a vascularized ulnar nerve and routing it around subcutaneous border of the neck. I think Shufeng Wang made a huge contribution with the prevertebral route. And I've actually used that route now. I've done a contralateral spinal accessory to phrenic nerve using that pre-spinal route. So now that I know it exists, it's another tool. It's another avenue to exploit. Yeah. So I think that the new way that he has described makes it viable again. And I would encourage anyone who wants to do it to visit either Wengdong Xu in Shanghai or Shufeng Wang in Beijing. They're lovely people to visit. Make sure your liver is in good condition, and you'll learn a lot from them.
Now, what are your thoughts on the donor site morbidity of some of the contralateral C7 transfers? That was also one of the criticisms of that. Have you seen a lot of that? Do you think it's kind of blown out of proportion?
So we've had, I can tell you about our experience. We had one patient where there was an aberrant takeoff of the posterior division of the middle trunk that was really proximal. Usually, the posterior division takes off fairly distal. In this one, it took off very proximal, and it was going straight posterior. So we missed it, and we cut distal to that. We ended up repairing it, but we were on pins and needles for a while. That child recovered wrist extension, finger extension, and triceps within about 6 months. But that was very tense. So I think technical error is to blame for the vast majority. The other time I would say that we aborted a contralateral C7 is we found an anomalous plexus distribution where we had C5 went directly to the posterior cord, posterior division. There was no upper trunk. And C6 went directly to the anterior division, and C7 was really small. And so we decided that it wasn't worth taking it in that situation.
Got it. We have Paige Fox on the talk from Stanford, and I believe Paige has a question. Paige, are you there?
Yeah, thanks, Dan. First of all, that was an awesome talk. I would have stayed for all 122 slides. But
like I said, it was a brand new talk, so I wasn't sure of the timing.
Yeah, no, it was great. I've always really been interested in, the kids who have this good elbow, good hand, good wrist, but, not a great shoulder where we think it should have come back. So I really like some of your thoughts on that. You talked about how the rotator cuff gets tight, and that's what really leads to dysplasia. Have you thought about intervening early and doing some sort of tendon lengthening or musculotendinous lengthening really early to stop this from occurring?
Yeah, so yes. What we typically do early, while it still has some stretch in it, sort of before a year, we will do Botox and casting to do a more of a stretch. And I think it's not that the shoulder, these muscles can't grow, is that they're less responsive to stretch. And so upping the game in terms of how much you stretch them, I think really helps in preventing the disease. In terms of what you're talking about, which is going after it early surgically, we tried for a while doing subscap slides as a way to try to get more external rotation. The problem with it is it's just going to stick back down. This is a lifelong issue. So no matter how much length you're going to get surgically, it's within a year, what you've done is irrelevant. So I think that's the big problem is if you could, we talked about stopping the growth of the glenoid. The problem is the glenoid has no epiphysis. It grows appositionally, essentially like an apophysis, which is something that Roger Cornwall pointed out to me. I thought I had such a great idea, and it wasn't such a great idea. The other thing we've been doing recently is coracoidectomy, and I think that's been a very powerful adjunct to a shoulder release. Partly because what happens is as the head goes posteriorly, the coracoid beaks and follows the head back. Removing the coracoid allows that head to come forward, whereas if you don't remove the coracoid, the head actually has to slip under the coracoid, and you get an abduction contracture as you're pulling the head further down. So getting rid of the coracoid, which has been done in Europe, and Idris Gerbawi has been doing it for years in Houston, and we really were late to that game. But I think that that's been a huge improvement in our practice is the coracoidectomy. We do all of our releases now with a coracoidectomy from the front.
And can I ask what age your typical patient is for that?
Typically around a year to two-ish, I would say. We've done some later that had good, that their glenohumeral joint looked good, but they lost external rotation.
Gotcha.
Yeah,
Thanks.
passively.
Thank you.
But that's around the age, a year or two. Thanks, Paige.
Great. Looks like Professor Bala from Chennai actually had a question. Professor, would you like to ask your question yourself? I'm not sure if your mic is there or not. If not, I can ask for you.
Don, it was an excellent lecture. So new thoughts have been coming. Now, do you ever do release of the coracohumeral ligament through arthroscopy to release the contraction of the shoulder joint? Has
Yes,
it got
yeah.
any role?
Yeah, I think that's an excellent point. When we do our coracoidectomy, we're going to the very base of the coracoid, so it naturally removes the coracohumeral ligament. I think that's a big deforming force. I totally agree with you.
Okay.
Yeah.
But still you do the transfer of latissimus dorsi and teres major to the infraspinatus?
So
Still
I would
continue.
say, yeah, so I would say the combination, we used to do, I'll give you the numbers. So we used to do about 3 to 4 teres or teres latissimus transfers a week, right?
Wow.
Now we do about, I would say if we do one a month, that's too many.
Okay.
And most of that has been because we do a lot more releases now than we used to, and earlier.
That's release.
Yeah, so we do more releases with fewer transfers, and we're doing more bracing, and we're much more aggressive with our Botox and bracing. So I think we've been much better at preventing the deformity, and therefore we're not treating as many.
Thank you. Thanks a lot. Yeah, that's what we also do. Number 2 is now we are slowly going for arthroscopic release of the coracohumeral ligament.
Yeah, so I think you can do that, and you can also do an arthroscopic.
Coracoidectomy.
Yeah, you can do an arthroscopic coracoidectomy. I think the coracoidectomy really helps. We have
Okay,
not
thank
seen
you.
the abduction contractures that we see with a posterior release that we see with an anterior coracoidectomy and release. Yeah.
Okay, thanks a lot. Thanks a lot. Yeah, it's a wonderful lecture. Thanks,
Thank you.
Baba, for
Yep.
bringing up this lecture. Yeah, thank you.
Great. Thank you so much. There you go. Dan, thanks again for being with us. This was a phenomenal talk, and I'm really excited about having it as part of our library for sure. And unfortunately, the Manus meeting this year got canceled because of COVID, so don't get to see you there. But hopefully I'll get to see you soon in person once all this stuff dies down a little bit.
Yes, agreed. Hopefully in Cuba very soon.
Yes, hopefully. Thanks again, and say hi to all of our friends in Philly, okay?
Will do.
All right, thanks,
All right,
Dan.
thank
Good
you so
night.
much.